Today, we're going to be talking about procalcitonin. What is it, and when and how should we be using it? We'll start with the case. Mr. Sepsis is a 68-year-old male admitted 4 days prior to the ICU with septic shock secondary to pneumonia. He was initially started on vancomycin and piperacillin tazobactam. Now he is afebrile, off vasopressors, and clinically improving. All cultures are negative times 72 hours. A repeat procalcitonin is significantly lower than on admission. Should antibiotics be continued? To answer this question, we first need to understand what even is procalcitonin. Procalcitonin is a precursor to the hormone calcitonin, but it behaves very differently in infections. In bacterial infections, procalcitonin is produced throughout the body, and thus levels rise significantly. It's usually lower in viral infections and non-infectious inflammatory states, though that's not a guarantee. So it's a helpful biomarker, but it's not perfect. Because procalcitonin is helpful in diagnosing bacterial infections, it is also helpful in guiding antibiotic therapy. Procalcitonin specifically shines in a few key clinical situations: lower respiratory tract infections like pneumonia or bronchitis, sepsis, specifically in critical care settings, and when the diagnosis is unclear, like post-op fever or equivocal imaging. Unfortunately, procalcitonin is not helpful in localized infections like cellulitis or abscesses. Procalcitonin is often low in these cases, even if there is a real infection. Now we'll talk numbers. A procalcitonin less than 0.1 is very unlikely to be bacterial. If the procalcitonin is less than 0.25, there's a lower probability of a bacterial infection. If it's greater than 0.5, that's more consistent with a bacterial infection. Absolute numbers can be helpful with procalcitonin, but the trend is often more important. A drop of more than 80% from its peak suggests the infection is resolving and stopping antibiotics may be safe. So what does the literature say about procalcitonin? The PROACT trial in 2018 found no benefit. However, a meta-analysis showed that procalcitonin did reduce mortality and cut down on antibiotic exposure. So, in general, the data is equivocal and we should tread with caution. So given the equivocal data, how should we interpret procalcitonin clinically? As always, we should integrate the data along with the rest of the clinical picture. We should look more at the trends over time. A falling procalcitonin is a positive sign. Lastly, we should probably not use procalcitonin levels to start antibiotics, but can consider using it to guide antibiotic therapy if there's a falling trend. Now, back to our case. This patient is afebrile, vitals are stable, no clear source of infection, and their procalcitonin has dropped significantly. This is a great scenario to stop antibiotics and minimize harm. So to summarize, procalcitonin is elevated in bacterial infections. It is especially helpful for lower respiratory tract infections, sepsis, and unclear diagnoses, but not for skin infections. A value of less than 0.25 means lower probability of bacterial infection, while a value greater than 0.5 means higher probability. A drop in greater than 80% of the procalcitonin means you should consider stopping antibiotics. But remember, clinical judgment always comes first.